Hello. Welcome to the Health Tech Talk Show live from
the eHealth Exchange annual meeting, I think it's called.
Yes, and we are here with very exclusive guest, Nakashima, CEO of the eHealth Exchange.
Yes, I've stepped out of the witness protection program for this.
Yeah.
President or the CEO?
President, whatever. It's all the same.
Speaking from experience, president is the best title you can possibly have in this industry, 100%.
All right.
Okay, so actually it's true. We have asked Jay to be on multiple times, and I think he just ignored us.
Yeah, that's probably true.
Yeah.
No, actually, I have never been asked.
Well, maybe we asked. Who knows? We can't remember. But
Call her out. Call her out. Call her out.
Listen, I got a lot going on. Anyway, so Jay, tell us what's going on at the eHealth Exchange conference.
The eHealth Exchange conference is an annual meeting that we have with our participants. It's a small, intimate conference. It's growing. This year we have about 200 people, and we're talking about all kinds of fun stuff for those in the interop space. We're talking about CMS aligned networks and TEFCA and exchange of data pursuant to authorizations. And then Ryan Howell's going to wrap it up, I think, later today with the talk about don't do stupid stuff. And then you, Kat,
she's before that.
I'm going to be here.
You're going to be inspiring us.
Yeah, wait. Let's just say this. So people know that I speak at a lot of conferences as an annoying person. And this time, Kat McDavitt is taking the stage for a very exclusive, very interesting perspective about
how to change someone's mind. We have a secondary title to the presentation though, and Lisa is going to feature prominently throughout, because if I didn't put Lisa in my presentation, she would actually comment anyway.
I was gonna skip it, but I guess I have to be there.
So I just made sure there's lots of parts. But anyway, so we obviously are very biased. This is currently the best conference we have ever been to, because both of us actually are speaking, obviously. Yeah, and all of our best friends, or at least ones that we haven't made yet. But Lisa was just on a panel this morning talking about CMS line networks, and it was actually really hilarious. Tell us more.
Yeah, well, we were talking about what is a CMS aligned network, why it is potentially a more successful possible future of actually sharing data in these United States. That was kind of it. That was the vibe. I was not the moderator, which was fantastic. Brendan Keeler was the moderator.
You did a great job.
You did a good job.
Yeah.
Well, and there was also the talk about whether or not the CMS aligned networks would replace TEFCA in care quality.
That's right. Yeah, and you said not really.
I said I doubt it. I think I said that change is slow, and I see CMS complementing care quality or TEFCA.
Yeah.
But who knows?
This is a pretty, so far, my presentation is obviously about non-real stuff, non-technical stuff, and it's about storytelling. And I actually think, so far, you guys have done a great job. You had Erica Olinsky talking about from the patient perspective and using your heart, not your brain with dumb facts in it to tell stories. Ryan Howell's got on that train earlier. I think everybody's done a really good job with that. And because the government opened up, you have some badass federal players here. You have Kim Brandt, Amy Gleason.
Yeah, we got lucky on that front. A number of the federal agencies, our participants weren't able to show up. They weren't able to get back to work and then request and process travel. But CMS is here.
Kim Brandt, who is the CMS Chief Operating Officer, Deputy Administrator.
Badass.
Also, Fraud, Waste, and Abuse Czar, I want to say, is her actual title. And then Amy Gleason, who runs the digital service / I think it's still called Doge, but fundamentally it's a digital service.
Also badass.
They're speaking, and honestly, Kim Brandt has done, she said she's done 3 tours of duty in the federal government, and she has seen a lot. A lot. There's a lot of fraud, waste, and abuse in Medicare. There's a lot.
Yeah.
And that's really astounding.
It's crazy.
I mean, the penalties are so severe.
Right.
I don't know how people have the guts to do it.
I think people are just not getting caught enough, and they might get caught more now.
Kim's going to catch them.
Yeah.
She's going to catch them. So Jay, what are we actually trying to accomplish with this conference? Other than have the clown show here.
It's really an opportunity for our participants to showcase what they're doing and try to collaborate with new use cases, new technologies, new policies, all that good stuff.
Yeah. So convening for awesomeness.
Yeah.
But I think I guess maybe I kind of paper over like the connections between right better and more frequent and trusted data sharing and all this other work. Like, can you talk about why would CMS be here? Why would they care about this? Why would they care about the eHealth exchange?
Why do they care?
Yes.
Well, Sam, I don't think this is one reason, but FYI, CMS was one of the eHealth Exchange founders 20 years ago. They promptly.
I remember because I did that whole slide, the 20 years of health information, and
yeah,
a presentation on that one. So I was like,
Yeah.
look, back in the day.
So they actually left the network in about 2019. They were using us just for end-stage renal disease reporting. But they really want to see, they're really vested to make sure that the national networks take their concept seriously, and that we adopt it quickly. So they're in it.
Well, you guys are also a pledger in
Correct.
the CMS aligned networks as a network, obviously, because you are a network.
Right.
And your team has been like leaning in. We were talking in the panel about how, it's very much like a community led effort. And part of it is literally like companies and organizations like eHealth Exchange, like putting some people on your team on this work to actually move it forward. Like Scott,
Right.
Tiffany, our architect and a product manager are like literally working on this and trying to build this out.
That's right. That's right. And of course, there are other companies doing the same thing. Be Well comes to mind. They're driving this.
They really are. Yeah. Well, again, it's like putting resources behind it, and you
Right.
guys are putting resources behind it, just like Be Well and others.
Right.
It's cool.
Tell me what happens if the CMS aligned networks effort succeeds. Look what happens.
I mean, what does the future look like?
What happens? Yeah. What happens to me, Kat McDavitt? Because that's what I'm worried about.
I believe as an
When you're in charge of the health exchange?
Just everybody knows that's a joke. It's like Lisa and me being the national coordinator together. That was a joke.
But we're still willing to do it, I think, is just what I'm trying to say. Like, if you want, like, we'll do like a
Tom Keene, if you need someone to take over for like your vacation,
Yeah, if you go on vacation, Tom, like,
we're
hit
your
us
girls.
up.
Don't worry. Everything will be just like you left it. Okay. Sorry,
Yeah.
Jay. Tell
Well,
us
so
more.
like, Kat, for you as an individual, I think it's going to be really, really helpful if you can get your data as an individual without going through heroic extra steps by going out to web portals and registering a second time.
Remembering 1,000 passwords.
Oh,
I do have a
God.
password manager, just to be clear, as should all of you, but
Yeah.
you still have to remember your passwords in many cases.
Right, right. So I think that's really kind
Get
of
a
the
password
big one.
manager.
Also, and this is just for interop nerds who would care about this, but also the use of FHIR APIs. So beginning to use more modern technology versus the old school CCDs or CCDAs.
Pushing documents around.
Right, right.
We're tired of that.
Well, that's very exciting. What about for providers? Like, what are they going to feel?
For providers, Lisa, what's in it for
Yeah.
providers off the top of my head?
Well, I mean, I think there are some providers who are really ready to redo their workflows around better, like more timely, more thorough, more complete data, right?
Yeah.
And so, the demo, so Innovacer is also a pledger. They did this demo thing. And what it was is taking a smart health link, so from Be Well or FlexBa, and basically like allowing you to scan the smart health link and then immediately import it either into the EHR or into an EHR overlay like Innovacer offers. And that makes it just way more flexible and easy. You probably, as a provider, you probably have patients walking up to you and putting their phone in your face and being like, look at my records. You don't have to do that anymore, right? That will be
That's
public
wonderful.
outcome, right?
Yeah, yeah. Also the
That's
incentives.
me being like, look at my records. They're like, I can't do anything. I don't know what this is in the EHR. I don't know what it is.
Yeah. I'm convinced that in future years, CMS is going to include this as part of their incentive program.
Totally.
In other words, if providers want to get paid, this is going to be one of their choices or requirements to get paid full retail.
Yeah.
So they
Yeah.
may as well prepare for it now
Yeah.
and join a network.
Totally. Agreed.
Yes.
So we've got like 100 guests here, and we've prepared for not a single one of them. So we're not sure if they've also
As usual.
prepared. It's TBD. But we are very excited to welcome our first guest. And Jay, would you please introduce this fine
I
gentleman?
would love to. We have the very astute Josh Lemieux here, who is
Someone's prepared.
I'm not laughing at you. I'm laughing at what's
We're
behind
laughing.
the scenes.
You can't see this.
soon.
Michael Marchant has arrived. He is our favorite unpaid correspondent. He's also our only correspondent, and he is wearing a security shirt with flames up the
You can
sleeves.
just do
Just
a quick
sorry,
visual.
Josh. 1
Do a quick
second here.
visual.
Here he is. Here he is. Boom, boom, boom. Just off his Tefka talk.
Yes, just off my talk with a goal to figure out how to sneak into the CMA Security Awards coming up. So as security, I'm going to pretend to be security. So currently fake security for you. So.
It's good to plan ahead for your conferences, appearances, and stuff like that. So anyway, back to you.
Yeah,
Jay,
yeah.
Josh.
Well, Josh, maybe I should ask you to introduce yourself because
Oh.
your role is so nuanced and so powerful. Don't be shy, but
That's what we
describe
say
what
when
you
we
do.
don't know what our guests do. So good job, Jay.
I don't know what you do.
That's news right there. I'm powerful. What am I going to do with this newfound power? I have no idea. But my name is Josh Lemieux, and I've worked in health IT on a lot of different projects for almost 30 years now. Started with the Blue Button Markle Foundation when we were hatching that as an idea, and I worked at Intel. Most recently, I was at Ochin, which is an amazing interoperability story in itself. But the reason why I'm here, and I'm so pleased to be with Jay, is quite a group of collaborators on a pilot to expand the use of the eHealth Exchange network for research. And so we worked with the NIH All of Us program in order to pilot doing queries on the network pursuant to the authorizations that all of us participants have signed to collect their EHR records. And we're here to the conference to talk about it because we think it shows a potential use case of all this infrastructure that we build around interoperability to get to medical breakthroughs by allowing authorized researchers to look at data.
Kat, you actually have an opinion on this.
Actually, you just answered my question because I was looking at this and I was like, how? Like,
I know what she was thinking. It was
I was like,
coming up.
who the hell are we going to get to convince all these HIEs to change their JERSA so we can do research, blah, blah, blah. And Lisa was working, so she was unable to comment appropriately. But you just answered it. You're using individuals.
Like me, who is part of all of us and has opted
Boom.
in to say, please take my EHR data and do research with it.
Because I was like, I don't think eHealth Exchange can do it, but they can if
You
the
sure
patient
can.
authorizes it.
That's right.
Oh, yeah.
Yeah, that's right. So, the reason for the exchange is not research, it's not treatment, it's not healthcare operations. The reason is that the patient went to the time and trouble to sign a HIPAA authorization form, put a cursive signature on it, and require that providers and other healthcare organizations disclose their data back to NIH All of Us.
And I mean, all of us has gone through some ups and downs, let's just say. And I think, just understanding like
Budget cuts.
right? But then that's a risk, as we always say, the pen stroke risk, the budget risk, whatever it might be. But the idea is still solid, and there are lots of people who have signed up and are like, yeah, actually, like, please do research, please like get something out of this. I'm good with that.
Yeah, absolutely. And one thing to keep in mind is the idea behind the All of Us program is that it would last a very long time. Obviously, the level of investment for the first decade is going to be a lot larger than what it's going to be for the next decades. But people have volunteered to allow their records to be used in de-identified form, but access to research community. And one thing that's really important about it is it's not just one study on a specific subgroup on a specific disease. It is this idea
general
that you
database,
build
right? Yeah.
a very large database with lots of multimodal information types and allow the research community to get qualified and be able to test any hypothesis that they want. And that investment only pays off if it is maintained over a lot of time. And the core of it is the trust that the participants have put by signing the consent. And that's what we were able to do. We put together quite a team with eHealth Exchange, Cedars-Sinai, Manifest Medics, which is the largest HIE in California. And we were the first.
Largest nonprofit.
Yeah.
HIE.
Okay, nonprofit HIE. We were the first to test eHealth Exchange for this academic purpose of querying records with a research purpose of use or an authorization-based disclosure purpose of use. And we were able to find very high match rates, and we were able to pull records that the program had not collected previously. So that was the whole
That's
thing
great.
that we were trying
Yeah.
to test. Are we able to use HIEs to supplement research data that wouldn't have otherwise been captured? So that's the power of the pilot, and we are expanding it currently.
Nice. That definitely confirms my hypothesis / confirms my pre-existing belief that you will be able to find other data if you go through HIEs, including, you know, state and national HIEs, HINs. EHRs will love to tell you they have all the data. That's just not how it goes, right? It's very hard, even within a particular EHR company, a particular vendor, even in a particular hospital, you have different, there's all kinds of reasons why it's hard to access. Whereas you can definitely get more when you look across HIEs and HINs.
So Josh, I love all these things you're saying. I don't necessarily know what they mean. So can you, so for the average human out there, AKA Kat McDavitt, like why is this like awesome? Like, why is it awesome that this pilot was successful and you're expanding it?
That's a good question. So let's imagine that you have gotten your you've signed up for the All of Us program
Me,
at
I
one
did it.
specific
She didn't do
place.
it.
Okay,
Lisa did it.
Lisa did
I
it.
did it.
You signed up at one specific place,
Yep.
probably, right? You were recruited at a site, and that site may be contracted with a program to provide.
Let's say it's UCSF.
Let's say it's UCSF. They may be contracted with the program to provide feeds of EHR data from their institution, but you may have gone to many other places.
I did.
And it would be very cumbersome for the program to, check with you to make sure, hey, can we get records from here?
And I
Can
wouldn't
we
even
get
know,
records
by the
from
way. Like,
there?
I have no idea. It's
Yeah.
been my whole life.
And
Here.
so what we were able to do was, because you have an authorization, we checked to make sure it was valid at the time that we did the query to the network. And we were able to pull records from other sources of data in California where you may have gotten care. And that can fill information about, medications that may not have been captured at UCSF. And the value of this is that there are all kinds of NIH-funded research that requires ongoing surveillance. And if that surveillance requires doing a DUA with every single institution where you might have been getting care, it's not scalable. But if everybody is part of the network and has signed the trust agreement that is, so important to eHealth Exchange, then sending queries on that network to get records back pursuant to the authorization that you provides some potential efficiencies.
Yeah.
And collecting research data is an expensive and cumbersome process.
Yeah.
Anything that we can do that maintains the trust of the participants, but also increases the efficiency is an exciting story for NIH.
And then they can cure cancer.
That's what I'm talking about. We're curing cancer here. Cool. A+, and all kinds of other diseases. That's what I was waiting for you guys to say, because I was like, what are we? Oh, we're curing cancer. Got it.
Or like whatever diseases, genetic or otherwise, I have.
Awesome. Love it. I do appreciate all of, yeah, I'm doing some stuff. That's awesome. That's awesome. So, Jay has a question.
Well, I was going to say, Lisa brought up genetics. And so many of us in the All of Us program, like myself,
Same.
decided to also provide a DNA sample. So I, donated saliva, and that was used to test. And so now there's my genetic markers, variants are documented. And if all of us chooses to get my medical records, they can supplement that and start to look for correlations.
Yeah. You might say why, and the reason is that like some of us are okay with our data being used for research, especially if it's in a way that, will advance, scientific understanding, cures for diseases, whatever else we can do to make help research advance. And there are a lot of people who feel that way, who are totally willing to, when there's not money being exchanged, to provide our medical records, our genomic data, whatever else.
One more important aspect, and it's right in the name of the program, All of Us. The reason why we know something, or we learned something about cardiovascular risk factors, was largely out of the Framingham study, which is based in a community in Massachusetts. And it's a landmark project. All of Us is at a much wider scale, and it is intended to recruit volunteer participants that are from the entire population living in the United States, because Framingham was not based on the whole diversity of
A lot
the
of Yankees
country.
there.
It also, an underrepresentation in biomedical research is itself
Yeah.
a risk factor. Many of the studies throughout the 50s and 60s barely had women in them. And so all of us is a significant investment to remedy this. And it's an exciting program to work with.
Nice. Kat, are you donating your data? What's up?
Listen, if everybody's got all my data, and especially if you incentivize me by telling me I can get through the Atlanta airport quicker, I will give you anything you want. So like, if you need more data, that's what I would suggest to you. Just like, that would be a great incentive. Like a special lane that just says, yes, that would be great. Oh, well, I don't know if you've been to Atlanta lately. Our pre-check doesn't matter. But anyway, so well, tell us, so you were talking about expanding the program. What does that look like?
So the eHealth Exchange Network has a very large install base or membership, and that includes organizations that have been traditionally part of the All of Us program sending EHR data. So we're testing an alternative means of acquiring that data, but also with more HIEs. And so we are currently recruiting organizations that are members of the eHealth Exchange Network and will be willing to respond to more queries, because we started with Cedars-Sinai Manifest Medics. I'm a big believer in starting with a few really good partners, and then you really only learn what it's going to take to scale after you've actually stepwised it up a little bit. So that's what we're working on now.
Nice. Very cool. Melissa is bringing the hook out.
All right.
Thank you for joining us on this high-risk
Josh,
low
thank
production
you.
talk show.
Next.
There.
Hey.
How's it going?
Well, Jay, introduce our guest.
I don't know if we've met before.
Oh my gosh.
so-
Oh, seriously? Oh, that's what I'm talking
No,
about.
Jay
This
and
is
I
my
have, but I don't think I've met you.
Oh. Well, I was
Very
going to
nice
say, like, no prep, no knowledge is the best kind of talk show. So, okay. Well, if Jay could please introduce you, and then you can introduce
Sounds
yourself, that would be awesome.
Yeah. So Karuna is with the Blue Cross Blue Shield Association out of Chicago, where she works. But they operate in, my goodness, how many different states?
All
All
of
50
them.
states. And so,
Just like the Health Tech Talk Show.
yeah. And so the Blue Cross Association is moving forward with payer provider exchange using modern FHIR APIs in a scalable fashion, and they're creating various services that their member organizations, so Blue Cross of wherever, can potentially take advantage of that. Karuna, would you like to correct me?
No, I think you did. You pretty much got it. Yeah, we're a federation of 33 independently operated Blues plans across the nation, and we recently joined the Health Exchange. I think we're one of 3 payer participants, and the other 2 are 2 of our Blues plans. So very excited to be welcome to the club, the organization. Definitely a new experience for us, being part of the kind of the common trusted agreement, the common agreement kind of network, and new paradigms for payers. So we're really excited to be at the forefront here.
This is really important because obviously we've been talking a lot about the CMS aligned networks construct, and on stage in the session we just said, one of the key factors as to whether all of this alignment we do on the technology side is going to work is if implementers, i.e. in this case, payers and providers, actually get involved, not just CMS. And so, it's very, very important. I'm really glad you guys are part of eHealth Exchange now, because that's like how we move this forward. And obviously the Blue Cross Blue Shield Association is also a member of Civitas Networks for Health and very involved, like leaning in, let's say, compared to maybe some others who are not leaning in quite so far, which is great. Big fan.
I might mention that that it's not realistic for providers to think that payers are going to join or going to license and pay for every payer platform. So if you have a given payer, let's say it's Cigna. Cigna cannot possibly pay for the Epic pay, the Athena payer platform, the eClinicalWorks payer platform, and I could go on for 30 different payer platforms. But so what we're providing is a scalable, low-cost solution to get data without paying the EHR vendors a fortune.
Yeah.
Doesn't that make the EHR vendors mad?
It could.
Well, and we're not,
It could.
and we're really not exclusive. There's a lot of, horses in the race right now. So we do partner directly with the EMR vendors. We partner with the national network exchanges, the different HIEs and data aggregators. And I think that's what's really exciting is how do we get to that next level of making this operationally and legally and contractually all make sense. Otherwise, we're going to be jumping hoops forever.
Yeah, it could be that national networks, TEFCA, CMS aligned networks, whatever, provide baseline functionality. And if the EHR vendors have additional services that we can't offer, given that we don't have a native solution to the providers, maybe it's worth it then for payers to pay that extra.
Well, I think there's also just been like now so many years of this an antagonistic view between payers and providers, including as it relates to data exchange, right? So treatment-based data exchange, a lot of people want to limit that to just providers, but the reality is the world is much more complex now. It's not a simple line, right? There are, provider-led health plans. There are payers who also operate under the umbrellas of much larger businesses that have providers and, offer and provide medical services. There's all kinds of ways that the lines have been blurred. And so this idea that you would just have this like hard, exchange is just for providers, what does that even mean anymore?
Yeah, I mean, I totally agree. And I think, we like to see ourselves as care partners, but by no means decision makers when it comes to treatment. And it's been interesting to see actually in the HL7 work group calls as it relates to burden reduction and actually implementing it, what is the responsibility of the payer to actually advise to an extent, or at least make transparent what those guidelines, those care guidelines are intended to be for the procedures. And a lot of times the payers don't want that responsibility. The providers have that jurisdiction. And so we see that tension actually play out in these standards development conversations. And hopefully we're earning trust along the way by being really clear about where we think we can be supportive versus, take the lead.
Yeah.
What was it about eHealth Exchange that made you choose them?
The inclusivity, absolutely. I think, especially with the association, we have the plans across the nation, and we're looking to, be at the table in a consistent manner as our provider partners and our payer peers. So we really appreciated being invited and welcomed. And actually, our plans that first joined Cambia back in 2023 was prior to the regulation. So we saw, the writing on the wall in terms of actually getting payers engaged, and where's a partnership that we can evolve and grow together.
Yeah. Just to be clear, by no means was I saying that like a physician or a licensed clinician should make a medical decision. I believe that, but I also just acknowledge that the landscape is quite complex now. And at the same time, right, this is what we always say in healthcare, right? There's never one boogeyman. Everybody is part of like creating the system. Yeah, everyone's the Spider-Man meme pointing at each other, right? Like providers aren't perfect, payers aren't perfect, right? Health technology vendors aren't perfect, right? We all have to work together to achieve whatever this is. And we have this major gap in data exchange right now.
Absolutely. Yeah, I like to think of the healthcare industry as like the housing crisis. In terms of it was no one's fault in 08. It was just it was a systematic lack of accountability. And
I don't know. I feel like it was someone's fault, but like, okay, like I'm here for you. Okay, keep
Karuna
going.
was making a point.
Keep going.
No, and that was it. Basically, we all have to take accountability and ownership, and in one way or another, it's going to circle back to us as our own patients and caregivers.
That's right. Yeah.
So what's next for y'all? This is your new kids on the block. You're doing stuff. What's
we
next?
are the new kids on the block, and we are working on getting our plans onboarded. So we, as Jay mentioned, have some initial use cases. Plans are very comfortable with sourcing clinical data. We don't have the same reliability of that required response. So there's some legwork that we need to do to make sure our plans provider partners are on the same page. So we're ironing out a lot of the technical, operational, legal components, and then hopefully we can hit the ground running and scale and actually have a repeatable model that doesn't require these individual point-to-point negotiations and really get to a standard, consistent way across the network. So hopefully we can earn our trust along the way.
So you got your goal is to get all the Blue Cross Blue Shield Association plans on eHealth Exchange.
Well,
The goal. I'm not committing. I'm just saying that's what you're going for.
and whether it's eHealth or another network that can get to eHealth, we're similar to CMS in that we don't have we can't mandate our plans to do everything.
Right.
So we're just providing them an option, so they can go through us, they can go directly to eHealth, they can go to another network and then connect to eHealth accordingly. But one way or another, they're all going to have to be exchanging data with each other. And ideally, we don't have them do anything that's unique to the Blues.
Right.
We're there to support them in the national landscape, but we don't want them to have to recreate anything just for our system.
Yeah, we also heard even from people who you might think, oh, they know everything. There's a lot of confusion in the market between like CMS 0057, CMS aligned networks, right? The pledges around prior authorization. There's like a lot of overlapping stuff. Like, are you helping the plan sort of also sort out like, here are all the things that you like have to do or could do, like dates, this is happening now.
Absolutely. And we're starting with just, CMS may be recommending these Da Vinci implementation guides.
You should do them.
We are 100%, you are doing it. Yeah, whether you like it or not, we are doing the Da Vinci implementation guides. And we've been at the table helping develop those as the Blues plans since the beginning. So we are really excited to see some of those things go into place. With TEFCA and CMS aligned networks, we as the association haven't made a commitment to either. I know some of our plans have pledged to be CMS aligned networks. We're just learning about kind of how they're being positioned in the market and then supporting our plans along the way.
Well, it's open. It's open for pledgers, also open for friends of the CMS aligned networks.
That's me.
Oh, okay.
That's
okay.
Kat's a friend.
Friend of
The homies.
Well, okay, so we're getting the signal from our boss Melissa here. So like, what last question for you, Karuna? So in 5 years, when Lisa and I are running the eHealth exchange and Jay is working on his tan and surfing at the beach somewhere, just give us like the two-liner, like, where do you want to be?
In 5 years.
I mean, obviously, like, assuming you stay at this job, where do you want BCBA to, whatever, Blue Cross Blue Shield Association? Where do you want to be in 5 years with this partnership with us?
We'd love to have a bus that's designated for payers. I don't think we have a bus right now without a healthcare operations use case properly aligned. So we'd like to be able to do a broadband query across the network and get responses reliably and know that data is going to be used effectively.
Yes, love it. That's
All
great.
right.
Awesome, Karuna. Thank
Yeah,
you.
Thanks for joining us. Thanks for popping on.
Thank you, Karuna.
Well, we'll see how it goes. We got lots of changes coming. Oh, and we're just popping her in. We have world famous. Jay, please introduce our guest.
World famous.
Erica was an inspirational speaker that we had earlier today at the eHealth Exchange annual meeting here in Nashville. And I don't know, do you have a brief version of your journey or your story?
I just want to go for it.
6 years of my life plus my career before that. Easy, yeah. Can summarize it. No, I think the heart and soul of the message that I really tried to bring out is that the patient and caregiver experience needs to inspire innovation, point blank over. Like that real world lived experience. We can't sit here and make up hypothetical patient stories to try to guide our use cases. We need real patients and real stories to help inspire and inform those.
And you actually started out working for a interface engine vendor, correct?
That's right.
Yeah, so you've gotten your hands dirty and you can imagine a day in our lives working on interoperability.
Yeah.
And you have the patient perspective.
Absolutely. Yeah. I mean, I think for me, this event's actually a little bit of a homecoming in my career in integration. I was not an engineer, right? I was on the marketing communication side of it, but I had to get educated on HL7 and standards and pick your standard, right? Your favorite acronym. But I got education on that, and it was fantastic to help provide context on the lived experience that ultimately I did go through with my son.
So I may have missed your presentation, but don't worry. Everybody told me about it. I've seen you speak before. I've gotten bits of it.
Michael Marchand cried, like some of us.
Everybody told me they cried. And it was inspirational. Ryan mentioned it on the panel with Lisa. Can you give our audience just like I know you can't really do this because it's a lot, but just give us like the 3-minute version.
3 minute of the,
Wow.
okay. So
Yeah. What was your big message?
yeah, I mean, so to recap a little bit of like the lived experience. So like was mentioned, I started my career in healthcare interoperability. That was in 2010. That was a high-tech, meaningful use era. So there was a lot of things happening. At the same time, social media was also coming online. No pun intended. Or maybe it was, but I'm accidentally punny. I need a shirt that says that. I keep saying that. Thank you for laughing.
Tina, get Erica a shirt. You can do it.
You need a
It's
shirt.
accidentally punny. My new favorite shirt.
Oh, right at the right time. Tina,
We'll tell you later.
you're crushing
I need a
it.
shirt that says accidentally punny because I walk into them all the time.
She don't know.
I just did it again. She just walked in here. I said I walk into them all the time. Okay, so started my career in this space, and then fast forward 9 years, really. So 2019, I have my second son, and at 5 months old, gets diagnosed with an aggressive form of brain cancer. I'm completely out of the blue, full-term baby, exclusively breastfed, doing all the things that I'm supposed to do, and just got completely blindsided. And so all of this contextual experience professionally just became immensely personal in that moment, because it was like, oh my gosh, this is why we were talking about empowered patients. What does it mean to actually have access to my health data, or my son's health data for that matter? And the challenges that we encountered as a caregiver and as patients in that journey were insurmountable. I mean, it was insane, the stuff and how difficult things were that did not need to be that difficult. And they were difficult because of systemic problems, because of just people being informed or misinformed about the realities of the caregiver and patient experience. And they were using that misinformation to inspire the innovation that they were developing. So ultimately, what became on the market was misaligned with the realities of what really was needed to support the care delivery process and the experience of the caregiver and the patient in that dynamic. And so it became so challenging. And as somebody who worked professionally in data sharing and interoperability and integration, it was the challenges were so obvious, and in some cases not even technical. They were just basic things like, oh, and I don't know the stats exactly on this, but somewhere in the ballpark of 80% of parents who wind up with a child diagnosed with cancer get divorced. So look at a stat like that as a reality of a lot of caregivers that have children that are facing these odds.
Right.
Well, why are we not like 4 to 5 patients have probably divided homes? So how are we thinking about that reality in the workflows we design? Because typically they're centered on the patient if they are at all. Let's say best case scenario they are. Well, they're not looking at the patient as a child who has to split their time between mom and dad at 50% or whatever it is. And so those logistical challenges are some of the things that we actually have to face as an industry. And so as we're thinking through these workflows, let's start there and then start innovating and talk. There's some basic stuff that needs to get solved too.
Well, and data portability and access is already so bad for an individual,
Golly.
much less any parent with their own kids, much less any parent with a kid who is going through a really serious illness, right?
Yeah.
Like compounds, right?
Yeah. And throw any workflow requirement or request outside of the workflows that exist today. Let's say I want to go submit a medical records request for some data that I own, right? Or it's about my son. It's insane how challenging it can be to just get that data over to where it needs to go. If it's outside, especially if it's outside of the typical workflows that exist. Because medical records doesn't know what to do with a request that asks for them to do something outside of what they're typically doing.
Right.
To no fault of their own.
And you will get
too.
a no if you ask for something.
Or they ignore you.
Or they ignore you.
Is really what happens. And
Yeah.
then you follow up. And say,
Like,
oh,
ooh,
we
put
didn't
that
know
one
what
to-
to do
put
with
that one to
that.
the
Well,
bottom
don't
of
tell
the-
anybody that we didn't do that, right?
Put that one at the
But,
bottom of the pile.
But that's the reality. And that's what happens is the requests are submitted and they're just ignored. And that's why things like legislation are so powerful and so important, because if we have accountability when it comes to access of medical records, that's where it comes to play.
Yeah.
Is, hey, provider, I asked for this. It's my data. I own it. You are accountable to sharing that with whoever it is I designated. Point blank over.
In whatever form or
You
format
can't just
I
ignore the
identify.
request because
That's
it
the
was
other thing.
complicated or it was confusing. You need to ask for clarity. It's the
Yeah.
same way any one of us would professionally
Yeah.
handle that.
Yeah. Well, again, the form and format also matters, right?
Yeah.
We've heard so many stories, heartbreaking and frustrating stories from patients who have had to walk around for years, decades, whatever, with like big old boxes of paper. By the way, the law does not say it must be in paper and you must charge me 20 cents per page or whatever. The law says form and format that I choose.
And that usability is so important too. So I actually did a webinar several years back with our good friend Grace Cordovano, where we were talking about non-medical uses of medical records, because there's lots of other places that our medical information needs to be usable or even just shared, right? It might not be physician to physician. It might be physician to school or
Sure.
physician to lawyer.
Sure.
And in those cases, how usable is it for those audiences too? Because we're talking predominantly around provider to provider interoperability. But what happens when you get outside of healthcare? It breaks down even worse than it was asking for the patient just to get whatever it is that they're looking for. When I requested my son's medical record in its entirety, this was several years ago, right? So this was several years ago in its entirety. It was a 60,000 page PDF document that was put onto a CD-ROM because they could not share it with me in any other format. I had to go on Amazon and buy a external CD-ROM, and it was a 60,000 page PDF. My computer could not even properly render that document fast enough for me to control find in it. And it's not chronological. It's literally a brain dump of whatever anybody can put in there. It's not organized in any sort of form or fashion. It's just a word vomit across 60,000 pages in a PDF.
That's so upsetting. It makes me
But
sad.
that is what's considered satisfying my medical record request.
Girl, check.
And that's unacceptable.
CD-ROM, sent off.
That's unacceptable. We cannot tolerate that sort of thing going forward. For us to actually, as an industry, be looking at ways to innovate. I mean, let's start there. Let's not have records shared as a PDF to a patient and just presume that their computer is also going to be strong enough to go and render that fast enough to make it useful. I can't even literally control find on the document.
Yeah, and you would have to build from scratch an AI tool to summarize that, because the stuff that's available to you as a consumer, even a regular business user, is not going to be able to handle that either.
I didn't
My
wanna
boyfriend
summarize it, though.
ChatGPT wouldn't be good enough, huh?
No, but I didn't even want to summarize it. I was looking for
make-
specific
even make
information in
use-
there.
Even make usable or fine, right?
Totally. Yeah. I mean, yeah. And then that doesn't include, that's just the record that's getting pulled from Epic or whatever, pick your EHR, right? That's not including other data that's coming from other sources. That might not be a in vivo drug screen that we work with a nonprofit to go do on tumor tissue that's resected from a second opinion that we get done across state lines.
Forget it.
Nobody's thinking about. So what do I do with that? I need that report now integrated with that. Who's going to do that? Nobody's doing it. No one's owning that connection. So that's going to just exist with me. Well, ChatGPT can help me out at least with the how do I make sense of both of these things. But it's not usable, and it's like we're missing the mark here in some really obvious ways.
So what are you excited about here with eHealth Exchange?
Well, I'm still like maybe to a fault a glass half full person. I've had enough trauma in my life at this point that I've conceded to the fact that my coffee cup always has coffee in it. It's just how it is. So what excites me, right, as an insatiably optimistic person, is that I think we can solve these things. I really do. We've got the right people in the room. We've got the right people inspired by the right stories. And honestly, AI excites me beyond belief in several ways, not in the hype fashion, but I think that AI is going to reveal to us channels of accountability that we've always thought intuitively existed. But now we're going to actually be able to hold people accountable to that. And that's accountability to each other too. As a society and as a community, what impact do I have on you, right? I mean, you and I don't get a chance to talk too much one-on-one, but we certainly share a lot of social circles, right? So, I mean, there's still an accountability between us, and that's true for every single person in this room. And that's true with everybody in our community, everyone in our neighborhood, everyone in our school, everybody in the city, pick your context of neighbor. But I think that AI is going to reveal those channels of accountability in ways that are unimaginable. And I think that's one of the most exciting things to me, because that accountability is also going to reveal where we can start to collaborate better together.
Awesome.
Love it. Well, thank you, Erica, for jumping in here.
You're welcome. Thank
Amazing
you.
and inspirational as usual. All right.
Did it.
We got our final guest of the special edition of the Health Tech Talk Show at the eHealth Exchange annual meeting. And we have the world famous, over and over, legitimately global public health leader, Michelle Meigs.
Well, hello. Thanks for having me.
Wait, are we not
Oh,
making,
oh,
making Jay?
this is
do
Jay's
that?
supposed to,
Yeah.
Jay's going to get, come on.
Yeah.
Come on.
So this is Michelle Meigs. She lives south of Boston, and she's with APHL, the Association of Public Health Laboratories, who,
That's why he's the
among
president
many
of
other
the Health Exchange.
things, operates the AIMS platform. And so they do an amazing job. They're an eHealth Exchange participant, and they do an amazing job of, among other things, distributing electronic case reports from all 50 states to state and local public health authorities. Michelle.
Did he
Thank
get
you
it?
for having me. He actually did.
Amazing.
He actually did.
We didn't have to say that she was from South Boston. She'll reveal that on her
No,
own.
I'm not
We'll
going to
find
drop
out
my
soon.
ass. Maybe one or two. This is so exciting.
Yeah, so what did Jay miss?
Well, specifically around case reporting, I think there's, public health has missed its renaissance. When we first
That's
got
one way to put it.
funding, right? So when we first got data modernization funding was January of 2020, right? The first dollars were rolling in. We
Crazy.
were all excited, right? We had worked for months, gone to the Hill, done all of this work. And by March, there's my March. By March, we had, I can't say March and I can't say drawer. I can't draw. So by March, we were in full on COVID response. And that lasted a good 3 years. And during that time, operationally, everything shifted to case reporting. And that's where we've been stuck ever since. And although it's extremely important, I think that there's a lot more to public health, specifically around public safety, right? And really understanding how do we get in front of some of these high consequence but low probability issues and outbreaks like C. botulinum right now in baby formula, right? It's growing, but there's no way to share data between FDA, CDC, the agencies. And I think that the beautiful part about public health is that we have been lagging behind a little bit, right? And we didn't get our chance. We're a little bit stuck in case reporting, but with the help of different networks and different HDUs and eHealth Exchange, we can maybe leapfrog healthcare, right? We can look at some innovative new technologies because nobody's been paying attention to the stuff on the ground. And it
Can you
doesn't
just
have to
say,
be
can you just say for a
expensive.
generic audience here, like, what actually do you mean when you say case reporting? Literally, when someone has a
So for me, because for me, case reporting is this tiny, it's a huge amount of data, right? I was thinking about what you were saying about the 60,000 pages of a case report. That's happening 30 million times a day, a month on for case reporting, and it's not usable data. It's very hard for the agencies to use it. And so from a case perspective, in my mind, it should be an initial case report, right? It should be one time.
roll back and say what it actually is.
Oh,
It
case
literally,
reporting.
someone goes to, let's say their doctor, and they have something that's called a reportable condition.
Measles.
Keep
Or a
going, keep
trigger,
going.
a trigger,
yeah.
right? So
say more-
something triggers
say
it.
the
in the EHR. The EHR, there
What's an
is a
example?
trigger
Measles.
code. So
Measles.
somebody, yes, they have a diagnosis
has
code
measles.
of measles.
I go to a lot of measles places.
Yeah, you never know. So that would then trigger the EHR to check that it's reportable in the jurisdiction that they're looking at, right? So like for flu isn't endemic. It's not reportable in every jurisdiction, right? And so it has to check to see who actually wants it reported to them and how, and it gets sent then to APHL and then distributed. But the original intent when we were looking at this before COVID, right, when we were just in that ideation phase, right, we had to go from ideation to scaling, national scale, right? We didn't get to incubate. We didn't get to understand, like, what does it actually mean to have a case report? Because we don't need it 5 times. The data just doesn't, it's not usable in that form right now because the surveillance systems aren't robust enough.
But the jurisdiction of data is also important here because public health has a really unique level of data authority that is very narrow, but also very, is that, what's the word I'm looking for? Maybe, but like,
Broad.
it's very narrow.
Narrow and broad.
Narrow
and broad.
It's very narrow. It's very narrow. It's only basically reportable conditions, but it's like public health at the local level, wherever that authority lives, can do, like, we can get data from everything. You must give data to public health. It's not like an option. It's only a few things, but it's like really, really serious in terms of their authority to get that data.
Yeah, I was going to say a case report is more than a lab report, lab result. So for COVID as an example, old tired example, but it might say, hey, it might be
Cat
from
also has COVID.
it might be from
I
a
have
provider.
had multiple case reports. I am sure.
Yeah.
Probably
But
two
it
hands
might
full.
it might say something along the lines of, hey, patient J was tested positive for COVID. And then it might go into the medications I'm taking. It might say, oh gosh, Jay was hospitalized, and then 2 days later, he was moved to the ICU, and he was put on a ventilator, and he was prescribed XYZ, and so on and so forth.
Yeah.
So it's a very
It's not
broad
just like he
report.
tested positive for COVID.
Yeah, and
It's much more than that.
and one of the
It's those
points.
60 pages that Eric was talking about of like all the everything.
Yeah.
Yeah.
And I'll say that, when I think about case reporting, I think of the day-to-day event-driven
Totally.
feed. You're looking for that one case or that one person at the individual level. But when you look at all of public health, you don't know what you're going to find.
Yeah.
Right. And so there's all of these novel cases that you really have to dig into, and you have to have a brain trust, and you have to have infrastructure to be able to scale it when there's no profit margin to do so. And so figuring out how do you patch together a coalition to figure out like what has to be federally funded versus what should be driven by the market versus what should be driven by innovation has been it's been a real complicated question to answer, because I don't even understand it. And I've done this since 1996. So I'm old.
All over the world.
All over the world. Yeah. I mean, APHL has country offices in 7 different countries. We do informatics, lab informatics specifically. And long term, this platform shouldn't live at APHL. This should be a community platform, right? This should be something driven and governed
Critical
by
infrastructure.
public health as critical infrastructure. And then we figure out who puts skin in the game. But that's where innovation is going to happen, especially with the lab data. I think lab data has a real transformational opportunity on top of case, because when you get into outbreaks, that's what they're going to be looking at. They're going to be looking at ELR data from all the clinical labs, syndromic surveillance, to be able to act and react.
And
so
what
it's
happens when we
fascinating.
don't have that infrastructure? Like, as we know, like we didn't do the best job with the data modernization funds. We didn't get the outcome we necessarily would have wanted. And like you just said, there are epidemics, there are potential pandemics that are spreading right now. Like, what happens when we don't have that?
Yeah. Well, everything gets categorically funded and funded year over year. Yeah. Right. And so for APHL as a membership association that we're trying to meet our member needs, we're also trying to figure out how do we get the dollars we need to actually fund this thing year over year. Even though we have a cooperative agreement with CDC, it's really not just CDC's responsibility, right? And so it's trying to figure out who needs to put skin in the game and how do we build that trust network, because it's really not the technology, it is the legal agreements and the trust between these organizations. So from a case reporting standpoint and an ELR standpoint, we allow the states to dictate not just what they're going to put in our CKMS, which is right now, reportable conditions knowledge management system.
And it's acronym.
That is a good name.
Right?
Call us. We'll rename it. When we're also running ASTP eHealth Exchange, we will help you.
Yes, please. Yes. Public health has terrible marketing skills. But what I was going to say is that there's a real opportunity, I think. And I don't think it's going to take a lot of money. It's just going to take some brain power to think through what happens next.
We really need the effort that is happening right now within CMS.
Yeah.
The same energy, the same people. Obviously, there's a problem because CDC is not looking great from a leadership perspective right now. But if we could do something like that, we could get people to come together. Kat, new idea.
Yes, when we are in charge of also the CDC, we will give you a call,
Absolutely.
Michelle. Okay, but really, so practically, I know APHL and eHealth Exchange have worked together for some time. What is the hope for the future with your partnership? What do you think you can accomplish together?
Yeah, so I think Michelle touched on it. It's much more than electronic case reporting. That's where the focus has been for the past 5 years, but it's lab results, lab orders, all kinds of things to case investigations to manage outbreaks. So I think it's a broad list.
One of the things that we're looking at specifically is around newborn screening, right? Every single baby in the entire country gets tested at a public health laboratory within their first few days of life, right? And they're tested for all their genetic conditions. And that has been a manual process to get data between healthcare and public health, right? And so there are really specific use cases where we can actually leverage. A healthcare organization actually went through eHealth Exchange, specifically asked their legal department, can we send electronic test orders and results for newborn screening through TAPCA. And we're like, I don't know, can we? Like, I don't know.
Let's find out.
So we're gonna investigate some of these interesting use cases. Again, low volume, maybe, but high impact, right? Who doesn't want to know?
Sure.
Yeah, we all love babies.
We all love babies, right?
That is a good
40%
move, y'all.
reduction in the turnaround time to get results back to. We've got 7 states up and running for public
That
health.
is
That's
fantastic.
40% reduction.
Yeah, that is fucking fantastic. Way
fucking
to go. Yeah. Yeah.
Doing something positive when it's very complicated and there's like a lot of negative commentary about public health. That's great.
Yeah, and a lot of drama, a lot of upset people, a lot of funding cuts. That is fantastic. Way to go.
You just got to do it.
Props to you guys.
Yay.
Woo-hoo! Yeah, that's awesome.
We're gonna
We're being told, we have been consistently told to shut up at this point by our boss, Michelle, or Melissa. I mean, Michelle's also our boss. So final words, Jay.
Enjoy Nashville.
Yay. Thanks for having me. This is
All
exciting.
right. Thanks, Michelle. Thanks to all of our special guests and to Tina.